So, extremity trauma, the 2017-2018 protocol updates. We've got, for comparison purposes, we've got the previous extremity trauma protocol from the 2012 NCEP protocols for anyone to review who needs to. And we've got the new up-to-date 2017-2018 extremity trauma protocol. The protocols are similar in several ways. Each one is primarily a guide that leads to multiple exits into other protocols based upon signs, symptoms, and other pertinent information regarding the patient. The pearls in each provide extensive pertinent information for the paramedic to consider in the treatment of their patient, and they focus primarily on the immediate treatment and mitigation of any further risk to the patient. Differences in the protocols. The new protocol specifies immediate aggressive bleeding control techniques that wasn't stressed quite so much in the previous protocol. There is an additional exit pathway to the crush injury protocol, which was not in the previous protocol. Consideration of an open fracture in the new protocol is in a very similar context to amputation, treated in many of the same ways. Also, there is more of a consideration of long-term consequences of an open injury, including open fractures and amputations. The long-term consequences of infection and the beginnings of the implementation of antibiotics in the pre-hospital setting. Extremity injury types, dislocations and fractures. With pulses present in these types of injuries, injuries should be splinted in the position found or in a position of comfort if the patient can tolerate any movement. If pulses are not present distal to the injury, the affected extremity should be manipulated in attempts to return distal pulses if at all possible. More injury types, lacerations and avulsions. Focus should be on the management of hemorrhage, including use of hemostatic agents if available. Consideration should be made for moist dressings on an avulsion injury if no hemostatic dressing is required. Partial avulsion injuries, if not contaminated with foreign debris, there should be an attempt made to return the avulsed area to the normal position before any dressing is done. Amputations, more severe injury type, obviously. After controlling immediate life threats, if possible, the amputated part should be retrieved and cleaned. The part should be wrapped in sterile dressing and soaked in normal saline. Secure the wrapped part in an airtight container and store the container on ice if possible. As mentioned earlier, looking long-term, the new protocols do include administration of Rocephin as an antibiotic to hopefully stem any long-term consequences. Pre-hospital antibiotic administration. Studies indicate a 40% reduction in infections in patients with open fractures or amputations if prophylactic antibiotics are administered within 60 minutes of the injury. Previously referenced studies support administration of broad-spectrum antibiotics in the pre-hospital setting. The common pre-hospital antibiotics include Cetaphan and Rocephin, with Rocephin being the antibiotic of choice for the Onslow County EMS system. Rocephin is, as mentioned before, a broad-spectrum antibiotic. The adult dosage would be 1 gram IV or IO administered over 30 minutes. Pediatric dosage, 50 milligrams per kilogram, IV, IO over 30 minutes. Indications pre-hospitally are an amputation or open fracture. Contraindications would be a history of hypersensitivity to this or other cephalosporins, or recent administration of any calcium-based medications, generally within the last 48 hours. Rocephin is preferred due to its effectiveness against a wide variety of bacteria and a lesser occurrence of allergic reactions in administration. Bleeding control options. This can apply in any of those previous injury types that we discussed. Tourniquets to start with. A tourniquet proximal to the injury site. You want to ensure that appropriate pressure is provided to tamponade both the arterial and venous blood flow to the extremity. There is a possibility of increased injury due to soft tissue damage at the tourniquet site, or if arterial flow is not stopped but venous blood flow is, could cause an increase in actual blood loss. The patient should be labeled with the date and the time of the tourniquet application for the next provider to reference. Hemostatic gauze is another popular method of bleeding control. It was developed initially for usage in the military operations in Iraq and Afghanistan. Active agents vary, but many times they are an animal-based protein or similar fibrous material, which enhances clotting in the injuries. Ideal hemostatic agents are able to stop hemorrhage from large arteries and veins within 2 minutes of application. Obviously, any of these major hemorrhages can lead to hemorrhagic shock due to the possibility of extreme injury. The hemorrhagic shock is a major concern. IV fluid boluses should focus on return of radial pulses, with fluid boluses being limited to 1,000 cc's or less of normal saline. Also, if the patient meets criteria under other trauma protocols, consideration could be made for the administration of TXA, especially if they fall under the multi-system trauma protocol. Just a quick synopsis. The major changes are designed to increase the short-term survivability of an extremity injury, including more focus on directly managing bleeding. And there's also the focus on long-term outcome via the prophylactic administration of antibiotics, which could hopefully prevent any of those systemic infections that can cause long-term death or disability. The end.